Good evening, everyone. My name is Alexis Davis. I'm the social media manager here at RSDSA, and I'm joined by two guests this evening, Dr. David Dickerson and Dr. Denis Patterson. I'm going to read a little bit about them today. So Dr. David Dickerson is the section chief for pain medicine at the NorthShore University HealthSystem and clinical associate professor at the University of Chicago. Dr. Dickerson served as chairman of the American Society of Anesthesiologists Pain Medicine Committee, as an advisory board member for the National Prescription and Drug Abuse Summit, and as a member of the AMA Opioid and Pain Task Force. He is an active researcher, educator, and advocate in neurostimulation, pain stewardship, and the taxonomy of pain, Dr. Denis Patterson is a board certified pain medicine and physical medicine and rehabilitation physician. He is the founder and owner of Nevada Advanced Pain Specialists in Reno, Nevada. He was nominated as one of the top 25 physicians in Northern Nevada by Nevada Business Magazine in 2012 and 2013. In 2013, under the leadership of Dr. Patterson, Northern Nevada Medical Center's Pain Center is the first and only center in the nation to achieve Joint Commission on Accreditation of Healthcare Organizations Gold Seal approval for lower back pain. Now, please remember that the information received here tonight will be helpful. Please consult your physician for personalized medical advice. Usually I would turn this over to Jim Broach for a few announcements. I'm missing Jim this evening. I will have to catch up with him later on this week. But before I turn it over to our guests, I do have two quick announcements. As you all know, our second annual virtual walk is next Saturday. We are so excited. We are 93% to goal, and you still have time to participate, to donate. Just head over to rsds.org/walk, and you will find all the information there about registering and donating to the walk. We will also have a live stream next Saturday that's going to take place at 1 p.m. Eastern. It'll be a 1-hour live stream to, highlight some of our top teams and just to get everyone excited. Be sure to wear your orange, wear your walk t-shirt if you purchase one. It is going to be a great afternoon. And my final announcement before I turn it over, we are going to take a brief break for our Facebook Lives for the summer. We hope to come back on maybe later in August or September, just to give some folks a summer break. So if you have any ideas for future Facebook Lives, please let us know in the comments, or you can send us an email. You all know how to get in touch with us. But enough about me. You did not come to hear me. So now I'm going to turn it over to our guests. All righty, all yours.
Good evening. Thanks for joining us. Thank you, Alexis, for the wonderful introduction. It's always a pleasure to partner with Dr. Patterson in discussing this really special, game-changing topic. I know that it has completely transformed my practice and most clinicians who have brought DRG therapy to their patients with complex regional pain syndrome. And so it's an honor to get to join this group, and thank you all for taking your time to attend. We're really going to look at how this is a very targeted, specialized, evidence-based treatment that gets to the source of nerve dysfunction and can really change the pain experience and improve quality of life. Take the next slide. A little overview here talking about the why, the importance of having solutions like this for chronic pain and what the chronic pain experience is, including talking about the therapy and the science behind it, the platform and system that will deliver this, as well as some of the advancements in terms of making accessibility to treatment teams more modern in regards to the NeuroSphere digital care platform, in which we're actually able to interact with our patients through live video feed, similar to a FaceTime platform or like this, to be able to actually program patients' devices from home to optimize therapy, as well as to engage them. And then talk about steps and how this therapy could be brought to your friends, family, and communities. Gonna go, and then we'll end with a Q&A as well. All right, let's go to the next slide and get going. So living with chronic pain, a heavy burden, highly individualized, and it's really important. The message I bring most of my patients every day is you aren't alone, and your case is incredibly unique, and we need to approach it with the best evidence available, but also recognize that an individualized approach is going to be needed. We recognize that it's one of the most common reasons that patients in America will seek medical care. It's associated with many impacts on domain or on many different domains of living, including mobility and function, anxiety and depression and sleep and reduced quality of life. The World Health Organization estimates that 1 in 10 adults are suffering from chronic or are diagnosed newly with chronic pain every year, and that 50 million people in the United States are suffering from chronic pain. The healthcare costs are massive from the needs in terms of medical costs, productivity, lost wages, rehabilitation programs, amounting to almost $500 billion. In regards to the impact of chronic pain relative to other diseases, it really is a silent epidemic in that more Americans are affected by this than diabetes, heart disease, and cancer combined. And unfortunately, also tends to occur most commonly in the prime of our life, and our ages of 45 to 64 years old, as we're establishing ourselves in our enjoying what we've established in our careers and family lives. And unfortunately, people aged 45 to 64 years old typically will begin to have the highest incidence of reporting pain that lasts longer than 24 hours at a time. We'll go to the next slide. So what is pain? Well, pain is the way I always teach is it's whatever the patient says it is. But it really, from a neurobiologic standpoint, is meant to be protective and to help us understand when our body is at risk of having harm to our tissue or our self and our cells. It occurs when special nerve endings called pain receptors or nociceptors send a signal that travels along the nerve to the spinal cord and to the brain. And in between the nerve and the spinal cord is where the dorsal root ganglion is also processing this pain signal. And we'll talk about how that's a very important junction and target for this therapy. The signals can be released in response to hurt, harm, injury, and also due to things like chemical changes within the body, like inflammation. Go to the next slide. Chronic pain is different in that this protective process that's meant to keep us safe, unfortunately becomes pathologic and aberrant or non-protective. It's typically defined as lasting longer than 6 months and really lasts longer than the typical course of recovery from a disease. So the pain ends up being out of proportion in its duration as well as severity over that time, and really can follow a specific disease or a metabolic injury like being exposed to a toxin or being exposed to some sort of derangement in our own body's ability to perform its functions, like with diabetes, which results in injury to tissue. It can also come from a trauma or an accident, or from a trauma with consent, also known as surgery, where the intent is to heal or fix something. And unfortunately, the process itself activates our pain processing system, our neurologic system. And then that activation, unfortunately, doesn't regress or return to a protective status after we've healed, resulting in perhaps chronic pain signaling. It also can be marked by challenges in controlling that pain, whereas acute pain often can be controlled with pain medications like opioids over a short course of time while the tissue heals after surgery or an injury. Chronic pain oftentimes is related to a more treatment challenging scenario. And the symptoms can include things that are listed here, like burning feeling, stabbing, tingling or numbness, or sharp sort of pricks and pin-like sensations. Now, dull aches or discomfort can be severe as well, especially if it feels like an intense pressure, which sometimes nerve injury doesn't have to be burning. It can be a squeezing or a twisting or a contorting feeling. And then tenderness that really can be associated with even just light touch. So where our sensory pathways start to get crisscrossed and light touch starts to talk to pain fibers. These are typical symptoms of chronic pain. And of course, the constellation can be different amongst individuals depending on the area of injury, the mechanism of injury, and also who the patient is. Next slide. When we think about treatments for chronic pain, we like to use a stepwise approach. And the stepwise approach really is just a framework. It's not one size fits all. We really have to think about what's the mechanism of injury, who's the patient in regards to their medical history, in regards to their goals, in regards to really their concerns. And we really like to leverage a shared decision-making approach to treating chronic pain, where we can be holistic and think about some of these first-tier therapies like cognitive and behavioral therapy, using some over-the-counter medications, or using things that are non-pharmacologic as well, like transcutaneous electrical neurostimulation, or even physical medicine to and occupational medicine to downregulate hyperactive nerves and try to get them to understand that while an injury was co-located in that area, that perhaps the tissue and structures are able to function without that pain in the form of things like graded motor imagery. The second tier here could include things like opioids, nerve blocks. We're seeing that opioids are becoming more and more of an agent that is moving further down the treatment algorithm for subacute and chronic pain due to the fact that there are side effect burdens from these medicines. That said, there's side effect burdens from lots of other medicines, and we have to recognize that therapeutics, whether it's a procedure or a medication, we really have to balance out the risks as well as the likelihood that we're going to see long-term sustainable impact from that therapy. This is where the individualized approach with continued assessment is important to understand when it's time to move to the next step or tier of therapy. The third tier can include things like radio frequency ablation, where we silence nerve pathways with radio frequency waves that allow the heating up of a insulated needle tip that allows for us to silence a nerve pathway. Implantable drug pumps are another therapy that has been in existence for some time, and the agents and approaches have been changing over time. We've actually found that smaller and smaller doses perhaps end up leading to better outcomes with implantable drug pumps. So while this is a older approach, it has many new ideas and new evidence associated with it. And then neurostimulation, including the Proclaim DRG therapy, may also be recommended when these other therapy options have failed. It's important to think of, it's not a one-size-fits-all framework, and it really comes back to the clinician working with the patient to identify goals, fears, hopes, and then really coming together to talk about what sort of commitment each party is going to have to those goals, and making sure that through education and communication, we can align the treatment plan to meet the hopes and address the fears of both parties. All right, next slide, please. When we think about DRG therapy, it's special and it's different. I hope that by the end of the talk today in our Q&A, we can all come away with a better understanding of why it's different and also why the outcomes are better because of those differences. Next slide. When we think about neurostimulation therapy as a whole, this isn't a new part of medicine, and it actually goes back to the times of the Egyptians, where we found in Egyptian medicine the use of electric fish to create sensations that compete with our nervous system signaling to treat challenging, complex pain. Fast forward to modern era, and for the last 50 years, we've been using neurostimulation in the field of pain medicine with varying success over the years. But recently, the numbers reflect about 34,000 patients are coming and having these procedures. By applying mild electrical pulses or waveforms across a part of the pain pathway, we're able to change the way various cells process the signals that are pain signals that are traveling in and out of the nervous system. It's thought that this is it's thought that this sometimes blocks signals or sometimes activates parts of the nervous system to be able to block those signals for us or return or filter out some of the extra nerve dysfunction signal that's causing pain, numbness, weakness, or coordination issues. This is something that tends to lead to the pain reduction and then also functional improvements over time. We also see that the brain responds over time to these stimulatory waveforms in different ways, with changes in mood, affect, perception, even separate from the response to the pain relief. Next slide. When we think about neurostimulation for complex regional pain syndrome and causalgia, or CRPS2, initial research really showed us that traditional SCS had minor improvements for patients with CRPS. We would have to use different frequencies from treating patients with other type of neurologic system-related pains, like failed back surgical syndrome. We would use higher frequencies, and there was a lot of work and focus on how do we improve the response rate in sympathetically maintained pain syndromes. And unfortunately, we were left really with a therapy that oftentimes is providing 50% of patients with 50% relief, which left a large number of patients still seeking therapeutic options. Alternatively, when we move away from stimulating the spinal cord and we start to think about other areas where we know neuroinflammation is occurring, like the dorsal root ganglion, we're able to actually achieve a much more targeted coverage of the specific area of pain. And we're able to more reliably predict where the electrodes would need to be, as well as what the stimulation is going to give us in regards to results. It's allowed us to treat more focal chronic intractable pain conditions. I'm going to go through some of the how that works, and then also some of the data that comes out of the impact that comes from its mechanism of action. Next slide. This different approach really looks to place a tiny 1 millimeter electrode array across the DRG. And because we're not trying to stimulate through the spinal fluid like a spinal cord stimulator would do, we use lower energy, and we have a much more predictable delivery of that energy to the dorsal root ganglion. When the energy is being delivered, the majority of patients actually don't feel anything different except a change in the way that their pain is experienced, or that the extremity or area of the body is able to function. The dorsal root ganglion is a cluster of cell bodies that are able to communicate with the central nervous system, providing something like a filter that filters out, or it screens out, unnecessary signals and keeps them from being able to travel up and be perceived. Those unnecessary signals can kind of be looked at as noise in the machine that's coming from the neurologic machinery that's been injured, or perhaps thinks that the body is still injured in an area after a trauma, or a trauma with consent, like I said before, surgery. So DRG nerves really are another area or a switching station that allows us to, through activating with a waveform, create inhibition of these unnecessary signals and change the pain experience. And this graph shows that the DRG is very specific and associated with each nerve root, and allows us to communicate with very specific parts of the body. So when we want to stimulate the upper leg or the groin, we might be placing one of these DRGs at the L1 or L2 nerve root on the side of the pain. And we're actually able, as you can see here, to not just talk to a singular area, but multiple areas with a single DRG. And the DRGs reliably map out to these areas, whereas in the spinal column, it can be unpredictable as to which parts of the spinal cord correlate with each part of the body, and whether or not, based on the amount of spinal fluid in the area, we're going to be able to get the right amount of energy in, independent of patient position, independent of the number of cells we need to cover. So this is why when we talk about targeted relief, we're really able to lay this in an area where where what we see is what we expect, or what we expect to get is what we're going to get the majority of the time for patients. Next slide. Really is a different approach in that it does allow us to be more localized and targeted. And it does help us get to more difficult to treat areas like foot, ankle, groin, hip, and pelvis. The lower body is really where we've spent the majority of our research at this point, and we have a lot of data that shows that in adults with CRPS and causalgia, DRG is a superior therapy to spinal cord stimulation, especially when we're trying to target areas like the toes. We believe that, or the pelvic structures, those areas are really challenging in spinal cord stimulation as they sit deeper within the spinal cord and perhaps are more challenging to get neurostimulation waveforms to. Next slide. So when we look at the Proclaim DRG therapy, we're able to actually see that the area of pain is with spinal cord stimulation. We typically would create neurostimulation after placing that electrode in the epidural space through a needle. And when we would turn on the stimulator, even though we were looking to target the foot, sometimes we would only be able to get to the ankle, or we could get the waist at the same time. And even if we really focused in on that small area we wanted to get, we still would end up with areas outside of the painful region that were a part of the mapping and also a part of where we were delivering the therapy. With Proclaim DRG therapy, we really can isolate to the nerve roots of interest, where we see the complex regional pain syndrome process to be occurring, or where it originated. And also by doing that, we're able to actually cover areas, like I said, the foot, where we might not have been able to before. Next slide. been proven to be safe and effective as a treatment, DRG therapy, and it's been studied in over 18 studies over 7 years. It provides first a test drive or a trial where you're able to actually see if the treatment is going to provide you with meaningful benefit and function over the time of a trial period. And that lead is taken out typically in clinic just by removing the dressing, and the patient is back to where they were prior to the trial. Typically, there's no tingling sensation felt with this type of trial, and we often try to avoid that as it typically lets us know that we're just above where we want to be with the programming. So most patients, at least 90%, will not feel any sort of vibration or stimulation in the area. 100% of the patients in my clinic do not feel that. It's something that we do our best to program around so that patients don't really feel anything except the relief. Next slide. When we look at the likelihood of response in our large study of CRPS patients receiving and causality patients receiving DRG stimulation, about 81% of patients, about an 81% reduction in pain relief was obtained in patients on a numeric rating score. So effectively, that 81% reduction at 12 months is a very meaningful metric, as this isn't something we see with spinal cord stimulation, that magnitude of relief. Additionally, 86% of patients were having persistent relief at 12 months. To be able to have that level of capture is a major change in neurostimulatory therapy. Next slide. In another study, a retrospective chart review where patients were evaluated for the magnitude at 2 and 3 years, we're able to see that this therapy is durable. So at 2 years and 3 years, 71 and 73% of patients are still responding. We also were seeing that mental and physical function was also improved immediately, and that these were sustained improvements. This is meaningful in that this doesn't just reduce pain, but it gets people back to doing the things that they were hoping to do when they set out on this path of seeking therapy. Next slide. Doesn't just improve pain, as I mentioned, but also quality of life. And these are things that we've really looked at in terms of research metrics, recognizing that the clinical significance here is really important for when patients come back and say that they're better. Reducing pain but not improving function is really a flat metric. We really want to see if physical function, social function, general health have improved. We'll go to the next slide. And in our studies, we've actually seen that over time, patients are able to have significant improvements in their quality of life improvement scores. When we look at the quality of life impairment by pain inventory, we're actually able to see that at the baseline, a score less than 20 indicates severe impairment. And over time, at the 3-month, 6-month, 12-month marks, we see a gradual improvement that is significant, taking patients into a minimally impaired state, significantly improving their baseline at 6 months and at 12 months. This is really meaningful, and it's very valuable, because at the end of the day, the ability to overcome the many changes that happen to our bodies from pain, that can be deconditioning or even related to hypervigilance and things that keep us from being able to re-engage our activities, are effectively changing over time. This is really meaningful when we're looking for game-changing therapy, in that this is how we know that our patients are coming back and able to tell us that they are truly better. Next slide. In regards to opioid reduction, opioid reduction isn't a zero-sum game. It really comes down to optimizing function. But what we see here is that as we utilize DRG therapy, this is a therapy that oftentimes replaces lots of the other medications patients are taking, neuropathic medications, opioids. And I tell my patients, when we start to use these therapies, your body's going to tell you when it's time for us to back off on those other things, because the new therapy, the DRG, is going to actually start to be the main event. And you're going to find that you're going to need less and less of those other medicines, because you're going to start to have side effects from those medicines. You're going to feel sleepier, even though you tolerated those medicines for a long time, because there's not as much work for those medicines to do. So at 3 months, in this retrospective review, 30%, there's a 30% reduction of opioids. 12 months, 93% of reduction, 98 at 18, and 99% at 36 months, with really a net outcome of 20 out of 21 patients being completely opioid free after 36 months. And again, that metric is something that isn't flat or in isolation. It's accompanied by the quality of life improvements that we were able to show. Next slide, please. So we're going to watch a video now of one of our patients' stories.
In July of 2006, my family was in a really bad car accident. And at the time, they thought I only slightly sprained my ankle. I had a little cut on my toe. As I continued on after the accident, trying to recover from it, I was a competitive swimmer and I was struggling to swim after the car accident, and nothing was the same. The way I walked was hard. I couldn't run anymore. I had a condition called complex regional pain syndrome, or CRPS, and my family almost didn't believe it at first. We even had to get second opinions, and sure enough, we had it, and that kind of was the start of my medical journey with CRPS. And they worked a little bit, but the pain kept coming back, and eventually I completely lost the ability to walk. I was eventually pulled from school, and I was on hospital homebound. It was probably a year of just surgeries after surgeries. At that time, I think I was at 55 surgeries and procedures. Around that time, we started talking about more long-term options for me so that I can live some sort of a normal life. And that's when they decided to try to do a spinal cord stimulator on me, which at that time we were nervous about, but we were desperate, so we did it. And when they put it in, it worked kinda, but in less than a year, about 6 months, it actually failed, and I was back into pains. And out of nowhere, after I was supposed to be fully recovered from the surgery, back to normal movements, the leads in my back fell and bird nested at the bottom of my spine. I first was, introduced to the doctor who was going to do like the DRG and gave me all that information, and I actually called my dad and cried because I was like, this is it, this is going to work. I've never seen better numbers, I've never seen a better promise to living a pain-free life. I believe that the DRG was going to help my pain. When I read about the statistics, when I saw that percent chance of it being successful were like off the charts in my opinion. And when I read that you weren't actually going to feel the stimulation, and when the doctor kept reiterating you're not going to feel it, you're barely going to have to change the settings, and he explained the science and the detail behind it, I was just like, this makes complete and utter sense. I don't know why anyone's doing anything else but this. Sign me up. We did the trial, and I was absolutely pleasantly surprised when I realized there was no constant stimulation. I didn't feel anything. It's just my pain slowly started tapering down and down and down. And that trial period lasted a week, and when they removed the wires and were letting my back heal before we went in to do the main surgery, I couldn't wait. I wanted the first appointment. I was ready to get that in. And when we were able to do that, I had just graduated Florida State and I was getting ready to go to grad school, and they were able to get the DRG stimulator implanted. Once they turned it on, I was off everything. I didn't need any pain medication. I was just back to my normal life. It's the least amount of pain I've been in since 2006 before the car accident, and I am living as a completely 100% functional life. Living with chronic pain, I definitely think it influenced my drive to the career that I'm heading into and kind of in right now. I've always wanted to go down the path of being a physician and being in the medical field, but after having the experience I did with the dorsal root ganglion stimulator and being a part of that clinical research for it, a whole new world of medicine kind of opened up for me. I know I still want to be a physician, I still want to go to medical school, but I also know that now I want to focus on innovative medicine. I want to be a part and help create devices like this. I think my advice for anyone who's suffering from chronic pain, it is important to prioritize yourself during that time and to find the best option for you and not let anyone put you inside of a box in regards to what should work.
Perfect. Thanks, David, for that first half presentation on the overview of CRPS and DRG and how it can benefit patients. And I just want to say that that video that we just watched is truly inspiring. But not only is it inspiring for probably other patients to see, but as a physician, I just want to reiterate that that is something that we see say day in and day out with the patients that we see in our clinic. And I want to highlight, kind of two things before I move on and talk about, the system itself and, the steps to getting an implant. But there was a couple of things that that patient mentioned during, her story that I just want to highlight. Number one, she talked about traditional stimulation. And I think, traditionally in the past, we've seen a lot of patients who are offered a stimulator for chronic regional pain syndrome before DRG was available. And what we found is that those patients, it, kind of, just like she said, kind of waffled. It may have helped, may didn't work, they were kind of 50-50 or on the border about it. And I think what we found is that a lot of patients, it initially may have given them some benefit, but long-term, the type of stimulation it was providing, which would, provided paresthesias, almost a vibration sense in the area where they're pain, eventually became painful or annoying to them, and they didn't like it. I think that's one of the reasons why the traditional stimulation failed. The other thing I want to highlight about that statement is that I see that even in my clinic to this day. I do both types of stimulators, and what I find is that my patients who get a traditional stimulator, I find a subset of those patients that kind of waffle. They can't tell me if it truly did or did not work. But when I do DRG, I find that patients are more definitive. I find that the vast majority of them, it works, and it works well, and they can say that with being definitive about it, and they don't waffle about the 50-50. But on the flip side, if it doesn't work for them, they're pretty definitive that it did not provide them any relief. And I see that all the time. And I think that's great, because as a physician, the last thing you want to do is put a therapy in a patient that doesn't help them long term. And I find that with my traditional stimulators, that is the case at times. And overall, as a physician, I try to judge success by two different things. Number one is how many patients get a trial, move forward with an implant, and then I also like success being on how many patients keep that implant in long term. And what David really highlighted is that patients, when this works, it works long term. As you can see, that patients, 73 or 74% of patients were still getting, significant pain relief 3 years out after having their implant. And I have to say, I see that clinically. We've kind of kept track of our success rate in my own clinic on doing trials and implants, and then how long patients keep the implants. So the first thing that we look at is trial to implant ratio. And the first thing that I would tell you is that I see about a 97% success rate. Patients who get a DRG trial want the implant and move forward with it. And so that's a pretty high number. Where traditional stimulation, I've seen that hover about 84%. The second thing that I really like to highlight is, once a patient gets implanted, how many people keep it in? And just kind of like the patient was saying, with traditional stimulation, it's kind of a 50-50 proposition. I have to say that I do implants for those, and I have 2 or 3 come out a year. I've been doing DRG now for 5 or 6 years, and I've only had one person asked to have the device taken out. And that was because 3 years later, his battery died and his pain had resolved. But all the other DRG stimulators I've put in, not a single person is asked to have it removed over a 6-year period of time, which I find remarkable. And I think that highlights exactly what Dr. Dickerson was saying. The fun part about today's presentation is now I get to highlight kind of the future. What is happening now? Why is Abbott and their DRG stimulation, what are they doing to make the patient more patient-centric and make this a great thing? So first and foremost, what I want to highlight is that Abbott has the only FDA-approved DRG system out there. So if your physician is considered doing DRG stimulation, I would definitely ask if it is the Abbott one that they're providing, because that is the only FDA-approved system in the United States. And just like I said, the Abbott system is very patient-centric, and it's meant to get you back to living a normal, healthy life. So the first thing is that DRG stimulation is very low energy. And that was one of the problems with traditional spinal cord stimulation, is it required a lot of energy. And so patients who had those devices had to recharge their battery. And there are some products on the market that patients got to do it on a daily basis. Others, they got to do it, once, maybe twice a week or every other week. And the problem with recharging is that, that's a point where it reminds you that you have a chronic pain injury. And two, it takes away from being able to do the things you love in life. So the great part about DRG is it's very low energy. It doesn't require you to get a rechargeable battery, so you can move on with life and only have to worry about, the life expectancy on that battery, which at normal settings is about 6.5 years. Next slide. And the other thing is that it's got up-to-date technology that goes with it. And I think everybody nowadays has a smartphone. We all are usually on an Apple product. And so what's nice about this device is it can connect with these Apple devices, which we're all very familiar with. The other thing that I highlight to patients is that not only is it top of the line technology now, but the system I'm putting in you will be top of the line technology in the future. And what do I mean by that? I always highlight, that I'm sure we all have gone in the past, gone to Best Buy, and we bought a brand new radio system. And about a month later, we look and see some ad that the latest, greatest technologies come out. There's a new radio system out there that's better than the one you bought a month ago, and there's no way to get yours upgraded or go exchange it for the newer system. What's amazing about the Abbott battery is that it has upgradability, meaning that after you have your procedure, you have the device implanted, any new technology that becomes available over the next couple of years, you can meet with an Abbott representative and they can Bluetooth it into the battery. And I've already seen that happen with this device over the last couple of years, that some newer technologies become available, and we've been able to offer to my patients without any further operations or surgeries to get them the best, latest and greatest technology at their fingertips. The other thing I like to highlight is that traditional stimulation, patients in the past were unable to get MRIs. The great part about the system is it is MRI compatible, and you are able to continue to get an MRI in the future if needed. Next slide. The other thing that I want to highlight is that they have a new platform with Abbott that's called Neurosphere. Neurosphere compromises 3 different things. It's the technology or controller that you have that's hooked up with the via Bluetooth to the smartphone or Apple products. Number 2 is MyPath, which we're going to talk about here in a little bit. And the third thing is Virtual Clinic, which we'll highlight. And I think it's very important that Abbott went and developed these technologies, because what we see when you interview or do surveys of patients, we find that 45% of patients use their smartphone for healthcare purposes. We find that 21% of consumers or patients out there, look at healthcare websites or use healthcare apps for taking control of their own health. And last but not least, besides healthcare things, we see that patients wear wearables, iWatches or Fitbits, things that they can track their how much they move, how well they sleep, and just how much exercise they get during the day. Next slide. Next slide. And so let's talk about Neurosphere. So Neurosphere is actually is the platform that I was discussing that Abbott has brought to the market. There is no other company that's brought it to the market, and it's got 3 different things. Like I said, it's got the patient controller app, which you can put on your own personal smartphone. The second thing is got MyPath, which we're going to talk about next. And the last thing that we're going to talk about is Virtual Clinic. Next slide. So MyPath, what is MyPath? MyPath is a digital health application that you can download to your phone. And so if you're a patient who's considering moving forward with stimulation, you can actually download the app, and it has ways for you to ask questions to get answers about what you're curious about moving forward with the therapy. The other thing that it has is it has educational materials for you to review so you can understand the technology better, make sure that it's right for your health condition, and that you feel comfortable moving forward with the stimulation trial. The next thing that it does is during your trial, it will keep track of how you're doing. So it is going to ask you daily questions about your pain, how well you slept the night before, what's your activity been like during the trial, and overall, what's your overall well-being. And what's nice about that is that those live updates get sent to your physician, your trialing physician who did the stimulator, so he can see how you're doing on a day out basis. My patients, I typically turn them loose after the trial for 5 to 7 days. I don't see them in the office because I don't want to influence their outcome unless there's a problem. And what's great about this app is that it lets me see if the patient's doing well. I continue to let them be, but every day I can check to see how they're doing. And if I see that they've fallen off or something's not working right, that may be an indication to me that I've got to bring them into the office, reprogram the device to make sure that we're getting the maximum results and getting the best possible outcome for that patient during that trial, to make sure that if they are a good candidate, they can move forward with the permanent implant. And what's also great is it can give me a summary at the end that I can print off. I can review it with the patient when I'm concluding the trial and making a decision on whether or not we're going to move forward with a permanent implant. And I can use that to submit to their insurance to get authorization and document how well things went during the trial. Next slide. So here's just kind of just an overview of what we just talked about. The first things that you can look at is it's got educational tools for you to learn more about the therapy. It will engage with you on a day in, day out basis of how the trial is going during it. And then, like I said, it will simplify your outcome. And at the end of the day, it also helps keep track of the individuals that are important that you need to maintain the device, whether it's your Abbott representative, your doctor's office, or the 1-800 customer service number. Next slide. So I think one of the other things that we've seen traditionally where stimulation has failed in the past is that there are times where patients need to be reprogrammed. And I think I saw a presentation by one of our colleagues that talked about that on average, it was about 9 reprogrammings a year. And I'm not talking about DRG. I see that it's much less for these patients. They don't need the constant reprogramming. But with traditional stimulation, they say on average, it's about 9 reprogramming visits a year. And on average, there's about 7 days that the patient has to wait to get reprogrammed. So think about that. That's 63 days a year that the patient's without their therapy. And to me, that's just unacceptable. And I can see why maybe a patient would get tired of that kind of the yo-yo effect. They're good, they're bad, they're good, they're bad. They got to wait a period of time to feel good. There's some wind up with that. And if you get wound up about your pain condition, you may get to a point where you're just fed up and just done with the stimulator, even though it helps you out. What's great is Abbott's developed the virtual clinic. And this is a way that we can interface with our patients and actually do reprogramming without having them come to the office. Next slide. And so far, I'll tell you, this is amazing therapy. And I'll give you a perfect example. I've got a patient who has chronic pain kind of in the tailbone or rectal area. They had a condition called coccydynia. and they ended up having their tailbone removed surgically, thinking that would resolve their pain. And unfortunately, it did not. She was desperate for answers and had tried multiple procedures, revision surgeries, nothing helped. And she found out about dorsal root ganglion stimulation and reached out to me via email. And I don't know how she found my email, but I responded back to her. And we ended up doing a webinar, or not a webinar, but a consultation via telehealth. Talked to her about the DRG therapy. And the patient ended up coming from Branson, Missouri to Reno, Nevada to see me. And I have since implanted her. She is doing fantastic, reporting significant pain relief, well north of 50%. But what's amazing now is at first I thought I would have to turn her over to the local rep in Missouri, even though she lives in a remote area and probably make it difficult for her to meet up with people to get, fine-tuned. But around the same time I saw and treated her, the virtual clinic came out. And so now we're able to see her on a, every month or every other month or on an as needed basis where I can connect with her. We can connect to her device and we can optimize her therapy. And I can tell you it's been a world of difference for her because she now can keep in touch with me and it's not, I can track her outcome. So that's amazing. Next slide. And so, I just want to highlight overall that, as we said, this is Bluetooth technology. The controller really personalizes your activity, that your access to this therapy and can make it a much better experience for you. Next slide. So what are the steps? If you're interested in getting a DRG stimulator, what are the steps? Next slide. So the first one is you talk to your physician, whether it's your primary care physician or somebody else who's treating you. What I think you're going to find is that they may or not be aware of this technology since it's so new. But if you can get them to refer you to a pain specialist who does the therapy, they can give you all the options and whether or not it is the correct therapy for you. If it is, then the next step is setting up the trial. The trial usually is a 5 to 7 day experience. And if the trial works, then getting it permanently implanted. And when I say permanent, it's not permanent in the sense that it can never be taken out if needed. It can be removed without, changing any of your natural body because we're not modifying any of your anatomy. Next slide. So the first step is to find a pain specialist, and I encourage you to get your phone out, scan this QR code. Unfortunately, there's a lot of data out there that says patients with chronic pain very rarely see a pain specialist. On average, it takes them about 10 years before they see a pain specialist. And overall, only about 2% of patients with chronic pain end up seeing a pain specialist. So I'd encourage you to take this out, scan this, and help find a pain specialist in your area. Next slide. After discussing whether or not DRG is with that pain specialist, if it is, then the next step is to set you up for a temporary evaluation. Typically, the trial can be done in a patient's office, at a local surgery center, or the hospital. That's where they'll put the leads to cover the nerves where they think will target your pain. And then they'll turn you loose. And during that week, what they'll want to see is if the pain gives you greater than 50% pain relief, if it increases your activity, and if it improves with your sleep overall. Next slide. At the end of the evaluation period, you'll sit down with your physician. You'll talk about all the benefits that it did or did not provide. And at that time, you will discuss if moving forward with a permanent implant is the right decision for you. Next slide. Usually the implanted system takes place somewhere between 2 to 4 weeks after the trial system ends. I have a lot of patients who threaten to leave my office because they don't want me to take the leads out from the trial since it works so well. But unfortunately, those leads have to be taken out and have new leads put back in. It requires the same leads, implanted battery, and the patient controller that you were very familiar with using during the trial system. Next slide. And overall, I just want to remind you out there that you are not alone. There are physicians such as myself and Dr. Dickerson that are here to help you. So please fill out an action card if you'd like somebody from Abbott to reach out with you and hopefully connect you with somebody. There's plenty of online resources to teach you more about DRG. So I'd encourage you to write those websites down. And then last but not least, you can join the Abbott chronic pain Facebook community and interact with other patients who may have the same condition with you. Next slide. And here's some QR codes. So once again, the top one is to help you find a trained physician in DRG. The second QR code is for you to get some online resources regarding the DRG therapy. And once again, the Facebook community that you can connect with is at Abbott Chronic Pain to hopefully connect with other patients who have the similar stories such as yourself. And hopefully find those patients who are able to get success with the therapies that Abbott is providing. Next slide. And with that, I'm going to invite our host, Alexis, back on and Dr. Dickerson to join me in a Q&A session. So hopefully we can make the most of this for all the patients and people out there who are watching. Thank you.
All righty. Well, thank you. That was a very informative session. I know we have a good number of questions in the chat, so I will kick it off. So the first question that we have, does the DRG help those with total body CRPS involvement? And quick follow-up question, what are the long-term effects of the DRG or spinal cord stimulator?
Dr. Dickerson, you want to go first, and then I'll fire after you.
Sure. So my approach to it's very rare that people started out with total body CRPS or sympathetically maintained pain. So I usually would first make sure that we fully understood what was causing the total body symptoms. And if the patient did have perhaps the initial focus of pain being in the lower extremities, I think that starting off with the CRPS diagnosis of a lower extremity that then spread, and I don't feel like there's a larger autoimmune issue that's separate or something else after a full neurologic workup, I would consider a trial of if that was still our diagnosis, because my experience has been, and I think Dr. Patterson would probably share the same, I think I've heard him say this a couple of times, the story and the history is so important. Find out where it started, treat kind of the epicenter, and I'll often see that many of the other symptoms improve over time or even during the course of the trial. That lets me know that perhaps this sympathetic maintenance is really originating out of the original injury site. Sometimes there's things like dysautonomia and other conditions that might be superimposed on the CRPS. And so rather than thinking about the total body pain as total body CRPS, which it could be sympathetic maintenance or autonomic dysfunction, being willing to say, okay, well, the burning foot pain could very well be causalgia, and then we'll have a treatment plan for what's going on elsewhere. I think it's really important to recognize that it's all about the right treatment for the right patient at the right time. And if the diagnosis is CRPS, being able to apply DRG to that site makes sense, recognizing though that you might need another treatment plan for the other components if they do not respond or maybe need a separate DRG trial to target those areas.
Yeah, I completely agree with Dr. Dickerson. I think one, making sure you have the right diagnosis that it is total body CRPS. And then two, look at the history. You're exactly right. Was there an inciting event, or was it just in one area initially? And actually, I can tell you that came important in my clinic. I had a case where a patient had a hip surgery. They developed CRPS afterwards, but when I first met him, the main complaint was foot pain. And so I did an L5S1 leads to target just the foot, and it failed. And then when you go back and talk to him, it was the hip that was the inciting event. So ended up doing leads, L2, L3 to more or less target the hip and the anterior thigh. And guess what? It succeeded. And actually his lower extremity symptoms went away. So if there is one focal area where it started, I think that's where you target. And then you're exactly right. If it helps that area, and then it can shut down how it had spread, that's great. If it doesn't, then you're exactly right. You got to look at alternatives to treat the wide body spread pain and make sure you have the right diagnosis.
I think the long-term effects of DRG stimulation, we have patients who've had these devices in for 5 to 10 years now, and the device is hermetically sealed. One of the things we think about when we place these is putting them in areas where leads won't move. Lead migration is something that we focus a lot on with any neurostimulator. Same thing with DRG. So making sure that the leads are in a place where they're not going to fracture or move. Part of that comes back to our technique, and also understanding who the patient is, recognizing that certain activities might need to be modified for a period of time, or perhaps the treatment like DRG needs to be thought about in a way of what are the person's favorite activities, and how can I make sure that the pulse generator, which is the little computer that's battery powered, is going to be in a place that's not going to be uncomfortable for the patient. And then also making sure that those leads aren't traveling from it in a way that's going to cause dislodgement. We have a couple different sizes of leads we can use in terms of length to add extra tension loops. And then we have lots of different approaches to make sure that we're coming at the DRG in a path that's not going to create tension points and things like that. The batteries have been tested to be hermetically sealed and able to stay in place for years without any sort of issue on the person's body.
Our next question, if you have had a spinal cord stimulator, can additional electrodes be implanted to stimulate the DRG?
I'll take this one if you don't mind. Unfortunately, right now we don't have a battery that can allow dual systems, meaning that if you already have an implanted battery with SCS leads into it, you cannot add DRG leads to that existing battery. Now, do I have patients who have an SCS system that worked well for them for years, but then developed a focal pain problem? Absolutely. So a couple of patients I can think of who had felt back surgical syndrome, they had pain from the back down through the legs, then developed, chronic foot pain later from neuropathy. I can got several cases of that where the stimulator is working well for their back and leg pain, but it's not helping the foot. I have actually then added leads, at L5 or S1 to help the foot pain. And when it succeeds, then I implant that system too. So I have patients who have dual systems, basically maybe, one battery that controls their dorsal column stimulator and the other one that will control their dorsal root ganglion stimulator. And to me, it's always fascinating to hear how they use the system. And they seem to like both and use them for different indications, which to me is amazing. And hopefully one day we'll have a battery that will allow you to use both systems on one battery.
Our next question comes from Jeff. He said, I've heard people can hear buzzing noises from a spinal cord stimulator. Does this technology do that as well?
I'm yet to hear in the couple hundred patients that I've treated with this any buzzing from any of the devices or heard that complaint. That's our practice. I haven't heard about that, and I don't think that that's I haven't seen that. Have you seen that, Dr. Patterson?
No, I haven't seen it either. I think they're talking about paresthesia and the vibration that traditionally felt. And what's fortunate about this therapy is that we know we can utilize it at very low energies. And so what we do is, and I'm sure you do this at your same clinic, you click it up to where the patient senses it. So that would probably be where they could hear it. But then we do several clicks down, and I've never had a patient tell me they feel any vibration or hear anything with this therapy. And you're exactly right. I've done hundreds and over, for 5 or 6 years, never seen it.
Can you talk a little bit about insurance and, how well does insurance accept, DRGs?
Yeah, I'll start out.
So I'll tackle this one. This is a major point. Yeah, go ahead.
Oh, no, I'll let you go. Go ahead.
So from an advocacy standpoint, it's really important to understand that oftentimes, if insurance denies this and it goes to a level of appeal, the majority of insurances really do have to follow the data. And there's enough evidence out there that at a state level appeal, we're often successful in getting patients covered. Some insurances do not have as robust coverage as for DRG stimulation and perhaps have a gap in their evidence basis or their policies. That's why the state level appeals are successful. That said, we are working at the level of many professional societies to continue to advocate that these policies reevaluate all the data for DRG and stop calling it experimental, especially considering the fact that we have level 1 evidence as well as real world outcome studies that show that the therapy is the real deal and that it's got a safety profile that deserves coverage as well as its efficacy. Having physicians committed to that part of the fight for you I think is really something that does set DRG doctors aside. We recognize that this is a frontier therapy, but it's been around for 5 years now, and we really are here to advocate and make sure that we can get access for our patients when the insurance, for lack of a better word, gets in the way.
I agree with Dr. Dickerson. You just got to, your physician has to be willing to go to bat for you. And anytime I see a denial for it, I request a peer-to-peer. And usually when I highlight that there's 18 studies over the last decade with 1,000 patients showing the benefits of this therapy, I think it's really hard for them to deny after they see that data.
So our next question, we've had this come up a couple times in the chat. How old is too old for a DRG? Like, is there an age limit? Can, someone pass a certain limit, age limit get a DRG?
Oh, no, the answer is no. I've implanted somebody in their 90s. You just want to make sure they're healthy. They can undergo that surgical procedure, even though it's very minor. And last but not least, you just want to make sure that their life expectancy is not limited at that point.
Yeah, I think that for me, it's all about the health of that patient, and I think life expectancy it's a hard thing to assess. But active cancer that doesn't have a high likelihood of treatment, that might be my only contraindication in regards to thinking about age and health status. We have ways to work around complex medical issues like blood thinners, history of you name it, history of anesthesia allergy. I've done these in creative ways to figure out how to keep patients comfortable without exposing them to the heavy meds or anything else like that. But I do think I've got a couple 90-year young patients, and that's the key. Are they 90 years old or are they 90 years young?
Good point, good point. So for our final question, if you have a spinal cord stimulator that is, let's say 7 or so years old, can you also, get in on the trial for a DRG? Are there any limitations there?
It's just like I was highlighting earlier. I've got patients who have a dorsal column stimulator that's been in there for years, and they may have a focal pain issue that stimulator is not helping, but it's helping the rest of their pain. There is nothing wrong with trialing them for a DRG and adding that to a battery on the other side if that's what they need. Do what's right for the patient.
There we go. All righty, y'all. So thank you so much. Thank you, Dr. Patterson, Dr. Dickerson, for this very informative presentation. And thank you for everyone who has joined us this evening. As always, we will have this video pinned to the top of our Facebook page timeline for easy access if you want to rewatch. If you have any additional questions for us or our guests tonight, or if you need a support group, if you're looking for a new physician, or if you want to tell your story on our blog, or if you have questions about our walk, we have so many different things going on. You can, of course, reach out to us at info@rsds.org, or you can send us a message here on Facebook. We will get back to you as soon as possible. Have a great evening, everyone. We hope that you have a great rest of the week and weekend. Bye, all.